Myocardial infarction, commonly known as a heart attack, occurs when blood flow to a part of the heart is blocked for a long enough period to cause damage or death to the heart muscle. A person experiencing a heart attack may feel intense chest pain, shortness of breath, and discomfort in the upper body. On the other hand, myocarditis refers to the inflammation of the heart muscle, which can weaken the heart and affect its electrical system, leading to rapid or irregular heart rhythms. Treatment for myocardial infarction often involves restoring blood flow as quickly as possible, commonly through medications, surgery, or medical procedures, whereas myocarditis treatment may include anti-inflammatory drugs, and in severe cases, medications that help support heart function or devices that help the heart beat properly. Risk factors for myocardial infarction include high blood pressure, high cholesterol, obesity, and smoking, whereas myocarditis is often caused by viral infections, autoimmune diseases, or exposure to certain toxins. Here are detailed aspects of myocardial infarction and myocarditis, each distinct in their impact on heart health. Pathogenesis origin, ischemic versus inflammatory. Myocardial infarction, MI, and myocarditis are both conditions that can have devastating effects on the heart, but their pathogenesis differs significantly. MI is primarily ischemic, caused by a blockage in the coronary arteries, leading to insufficient blood flow and oxygen to the heart muscle, resulting in tissue death. Risk factors include atherosclerosis, hypertension, and diabetes. In contrast, myocarditis has an inflammatory origin, where the heart muscle becomes inflamed due to infections, often viral, autoimmune disorders, or toxins. Differentiating between the two is crucial, as MI generally requires immediate intervention to restore blood flow, often through medications or procedures like angioplasty, while myocarditis might involve managing the underlying infection or inflammation with medications such as steroids or immunosuppressants and supportive care. Typical onset, acute and sudden versus acute to subacute. Myocardial infarction, MI, commonly known as a heart attack, often presents with acute and sudden symptoms, typically chest pain or discomfort, which can be severe. The pain may radiate to the arms, neck, jaw, or back, and it's usually associated with sweating, nausea, and shortness of breath. Conversely, myocarditis, the inflammation of the heart muscle, can manifest more variably, ranging from an acute to subacute onset. Patients may experience chest pain, which is often less intense and more localized compared to MI. They might also have flu-like symptoms, including fever, fatigue, or palpitations. The subtleties in symptom presentation and temporal development are crucial for clinicians to consider for accurate diagnosis and timely treatment. Primary affected population: older adults with risk factors versus younger individuals without classic cardiovascular risk. Myocardial infarction, MI, typically affects older adults who exhibit risk factors such as hypertension, high cholesterol, diabetes, and smoking history, hallmarks of atherosclerotic cardiovascular disease. These factors lead to the development of coronary artery plaques, which can rupture and form a clot, ultimately obstructing blood flow and causing tissue death in the heart muscle. Contrarily, myocarditis mainly strikes younger individuals, often without the conventional cardiovascular risks associated with MI. Myocarditis is inflammation of the heart muscle, usually precipitated by viral infections, immune responses, or environmental toxins. Its symptoms can mimic those of an MI, yet the underpinnings differ, often entailing an autoimmune or infectious etiology rather than atherosclerosis. Understanding this distinction between the disorders is critical for appropriate management, as treatments diverge significantly. Cardiac biomarker trend, typically elevated and patterned versus may be elevated but less specific. When distinguishing between myocardial infarction, MI, and myocarditis, cardiac biomarkers provide critical insights. In the case of MI, there is usually a pronounced and predictable elevation in cardiac biomarkers, such as troponins, which peak and then gradually decrease, following a pattern that correlates with heart muscle death due to ischemia. Conversely, in myocarditis, an inflammation of the heart muscle, often due to an infection or immune response, these biomarkers may also be elevated, but the pattern is less distinctive and specific. Troponin levels in myocarditis can be erratic, and do not necessarily indicate the extent of myocardial damage as they do in MI, complicating the diagnosis and the subsequent clinical approach. Understanding these biomarker trends is essential for clinicians to accurately diagnose, assess the severity, and manage the appropriate treatment for patients presenting with acute chest pain and suspected cardiac conditions. Response to treatment, revascularization focus versus immunomodulatory management. Myocardial infarction, MI, and myocarditis, although both affecting the heart, require vastly different treatment approaches due to their distinct pathologies. With MI, the mainstay of treatment is revascularization to restore blood flow to the ischemic myocardium. This is often achieved through angioplasty or bypass surgery alongside medication like antiplatelets and statins. In contrast, myocarditis, characterized by inflammation of the heart muscle often due to viral infections or autoimmune reactions, typically requires immunomodulatory management. Treating myocarditis might include corticosteroids and other anti-inflammatory agents to reduce inflammation and prevent further damage to the cardiac tissue. Understanding this differential response to treatment underscores the need for accurate diagnosis to ensure appropriate and effective management of these conditions.